So skip the coffee, grab your notes, and let's just jump straight in. If you're preparing for the FRCS in plastic surgery or, your equivalent board exams, your very first step, literally right now today, is to head to medsynclimited.com.
Right, exactly.
You need to get the plastic surgery board exam revision ANKI deck. It contains over 7,000 questions arranged by topic, covering the entire breadth and depth of the plastic surgery curriculum.
Yeah, the whole thing.
And it is meticulously based on the textbook Keynotes in Plastic Surgery. It's designed to just completely transition your study habits from passive, frankly ineffective reading into aggressive active recall.
Which is so critical. I mean, active recall isn't just some study tip. It is the absolute prerequisite to surviving the sheer volume of this curriculum.
Yeah, if you can't pull the answer out of thin air under pressure, you just don't know it. So it
Yeah.
really is the ultimate go-to companion for your exam prep. Do not waste your time staring at textbooks. Get the deck, drill the facts, and pass the exam. So our core mission today is to augment that active recall for, honestly, one of the most heavily tested areas on the board. We're doing a comprehensive rapid-fire Q&A deep dive into the breast and chest wall chapter.
It's a massive topic.
It really is. Aimed squarely at you, the resident preparing for the boards. So no basic intros today. We are getting straight into the surgical mechanics, the precise clinical anatomy, the pathology, and those complex reconstructive algorithms.
Because the goal is that when you sit down for your Viva, these concepts aren't just memorized lists. I mean, they need to be 3D models rotating in your head.
Exactly. All right, let's map it out. Before we even talk about surgically altering the breast, we have to establish the unshakable foundation of normal anatomy.
Yeah, they will always start you here just to make sure you're a safe surgeon.
Right. So let's define the exact vertical and horizontal borders of the breast space footprint. And then I want to drill down into the specific structural hierarchy of the lobes.
Okay, so mapping the footprint on the chest wall. The vertical extension is rigidly defined, right? From the level of the second rib down to the sixth rib.
Okay, second to sixth. And horizontally.
Horizontally, you're looking at a continuous extension starting medially at the lateral margin of the sternum and extending laterally all the way to the anterior axillary fold.
Right, but we can't forget the axillary tail of Spence, right?
Oh, absolutely not. The boards love the tail of Spence. It's this highly testable prolongation of breast tissue that extends superlaterally, and it actually pierces the deep fascia to enter the axilla itself.
So if I'm visualizing this in the OR, violating that anterior axillary fold boundary laterally means I am suddenly in axillary territory.
Yeah, exactly. You're risking lymphatics and nerves that you literally have no business touching during a standard breast procedure.
Right, like if I'm doing a mastopexy, I need to know where that lateral boundary ends to stay out of the axillary fat pad and away from the intercostobrachial nerve.
Precisely. Now, looking internally at the parenchyma, it's not just a random collection of fat and gland. It is a highly organized radial architectural system.
Like spokes on a wheel, right?
Exactly like that. You have 15 to 20 distinct lobes radiating outward from the navel. And if we break a single lobe down microscopically, each lobe contains a variable number of lobules.
And inside the lobules.
Inside every single lobule, you have 10 to 100 alveoli, which are the fundamental secretory units of the breast.
Okay, let's trace the plumbing of that secretory system, because the ductal anatomy is exactly where the examiners will trap you when they pivot to oncology. How does the fluid actually drain from those microscopic alveoli all the way out?
Well, it's a converging tree. Each alveolus drains into a microscopic alveolar duct. These tiny ducts then converge to form a single larger duct for that specific lobule.
And then they merge again.
Right. As they travel toward the nipple, they merge into major lactiferous ducts, one for each of those 15 to 20 lobes. And right before they open onto the surface of the nipple, they dilate to form the lactiferous sinuses.
So the critical exam point here, the reason we care about this plumbing, is that the vast majority of breast cancers originate right inside this ductal system, right?
Exactly. They don't start in the fat or the main stroma. When we say ductal carcinoma in situ or DCIS, we are literally talking about a malignancy confined within the walls of this specific microscopic piping system.
Before it breaks through the basement membrane. Okay, let's move from the plumbing to the structural scaffolding. We have the suspensory ligaments of Astley-Cooper versus the horizontal fibrous septum of Wieringer. The boards love the biomechanics here.
Oh, they definitely do. It's a critical distinction between structural support and surgical utility. So the fibrous septa in the upper pole are robust and well-developed.
Those are Cooper's ligaments.
Right. They are the primary structural support suspending the breast tissue against gravity.
Mm.
When a breast sags or decoses over time, it's because Cooper's ligaments are physically stretching.
But Weringer's septum is totally different.
Entirely different. Weringer's septum originates deep down from the pectoral fascia, roughly along the level of the fifth rib. It projects anteriorly, curving upwards, and it integrates into vertically oriented medial and lateral ligaments.
So it's basically attaching the gland to the sternum medially and the pec minor laterally. It sounds less like a vertical cable and more like a horizontal hammock.
A hammock or a structural shelf in the lower half of the breast, yeah.
And why is this specific shelf the golden ticket for surgical pedicles?
Because that shelf is a neurovascular highway. It carries the main nerve supply to the nipple, along with a dense network of intercostal perforators.
So if you preserve Weringer's septum in your pedicle, you're guaranteeing the neurovascular integrity of the nipple areola complex. Let's map that highway. Run through the arterial inputs, and then I want the specific nerve that supplies the nipple.
Okay, arterial supply is robust, coming from 4 regional sources. Medially, you have the internal mammary artery perforators, which are the dominant supply, especially the second, third, and fourth.
Right, superior.
Pectoral branches of the thoracoacromial axis. Laterally, you've got the lateral thoracic artery. And deep, coming from the chest wall, you have the lateral branches of the third, fourth, and fifth intercostal arteries.
And the wiring, the sensory innervation.
It's a web. Medially, anterior cutaneous branches of the second to sixth intercostal nerves. Laterally, lateral cutaneous branches of the third to sixth.
But the absolute high-yield answer for the nipple.
The lateral cutaneous branch of the fourth intercostal nerve. It enters the deep surface of the gland and travels superficially to reach the nipple. You have to know that one.
The fourth lateral cutaneous. Okay, let's talk about Penn's measurements. We are constantly taught these ideal surface numbers. What are they, and why do we even care about the mathematical method of bra sizing for a surgical board?
Well, Penn's measurements are the classical surgical benchmark for proportion. He described a golden triangle. Sternal notch to the nipple is roughly equal to nipple distance, averaging about 21 centimeters.
And nipple to IMF.
Approximately 6.8 centimeters, with an areolar diameter usually between 3.8 and 4.5 centimeters. You use these to restore proportion during a mastopexia reduction.
But the UK mathematical method for bra sizing, it's notoriously variable in real life. Why is it heavily tested?
Because it forces you to demonstrate a systematic understanding of volumetric geometry. You calculate the band size by measuring the chest circumference tightly at the IMF in inches, and then you add 4 or 5 inches to get an even number.
So a 29-inch IMF gets a +5, making it a 34 band.
Exactly. And the cup size is just the difference between that band size and the maximum chest circumference around the fullest part of the breast. Less than 1 inch is AA, 1 inch is A, 2 is B, 3 is C, 4 is D, and 5 is ED.
It's just quantifying breast projection relative to the thorax space? Makes sense. All right, moving to breast reduction and mastopexy. The boards love a historical matching question here. Let's do a rapid-fire era and surging match, starting with the 1920s.
1920s was thorac. He described the free nipple graft. The problem was extreme gigantomastia, and they couldn't move massive tissue while keeping the blood supply. So he just completely detached it as a full-thickness skin graft.
But that severs the ductal system and the fourth intercostal nerve. Zero lactation, zero sensation. So how did we evolve in the 1950s?
1950s, Wise introduced his famous keyhole pattern, the inverted T-scar. It gave a reproducible geometric skin excision to cone the breast.
But Wise is just a skin map.
Yeah.
1960.
Stromback. He described the horizontal bipedical technique. Very safe vascularly, but biomechanically restrictive. You couldn't get good projection. So in 1963, Scoob modified it into the supermedial pedicle.
Okay, 1972.
McKissick. He introduced the vertical bipedicle. You fold the pedicle on itself like a bucket handle, but it left the breast looking boxy over time.
Which brings us to 1975, arguably the biggest paradigm shift.
Ribeiro. The inferior pedicle technique. The absolute workhorse. It bases the nipple on a pyramid of tissue from the IMF, capturing those deep perforators and the fourth lateral cutaneous nerve beautifully.
But women hated the long IMF scar from the Wise pattern. So who popularized the vertical scar in the 1990s?
Lejour, the Lancers originally described it. Lejour used aggressive lipo and a vertical-only skin excision. It looks bunched up initially, but settles beautifully.
And Benelli in 1990.
The round block technique for smaller reductions. No vertical scar, just a hidden scar around the areola.
1999, we see a fusion of techniques.
Hall Finley. She took Lejour's vertical scar pattern but combined it with a robust medial pedicle. Huge projection and safety. Also, Hammond introduced the spare technique around then, using a short scar with an inferior pedicle.
And finally, 2005.
Hamdi. He designed pedicles specifically based on Weringer's septum to guarantee vascularity and sensation.
Great timeline. Now, if thorax-free nipple graft destroys sensation and lactation, when do we ever actually use it today?
Only when pedicle biomechanics become too dangerous. Think massive gigantomastia in an older patient with comorbidities, maybe a smoker. If you need to remove 2,000 grams per breast, the pedicle to carry that nipple up would be incredibly long.
And a long pedicle means the microvasculature fails at the tip.
Exactly, leading to total nipple necrosis. The free graft avoids that morbidity completely, but the trade-offs are absolute loss of sensation and lactation.
Let's unpack the inferior pedicle workhorse. What are the absolute non-negotiable rules in the OR to prevent it from failing?
First, the pedicle must remain firmly attached to the underlying pectoralis fascia. Do not undermine the base, or you sever its life support from the deep perforators.
And the design of the base.
It shouldn't just be vertical. Incline the base laterally to deliberately capture that fourth lateral cutaneous nerve. And third, respect tissue density. If the breasts are very firm, narrow the Wise keyhole pattern. If you force firm tissue into a wide envelope, you'll get T-junction necrosis from tension.
What's the cardinal rule for nipple placement?
Never, ever cite the NAC too high. Gravity pulls differently when they are supine. As the breast bottoms out over 6 months, a high nipple will end up pointing at the sky.
A nightmare to fix. So where should it sit?
At the end of the procedure, with the patient sat up on the table, the nipple should lie just slightly below the absolute most prominent projecting part of the breast mount.
Let's contrast that with the medial pedicle, the Hall Finley. How does a medial block of tissue push the breast forward?
Well, you dissect down to the chest wall, preserving a thin layer of areolar tissue over the pec fascia. You resect mostly inferior and lateral tissue. Then you rotate that medial pedicle upwards and laterally.
And the structural trick.
The inferior edge of your medial pedicle is sutured to the lateral breast pillar. The pedicle itself actually becomes the medial structural pillar of the new breast. The skin just passively redrapes over this new glandular cone.
Brilliant. Now, mastopexy. The breast has deflated and fallen. Break down the Rednaugh classification of ectosis.
Grade 1, minor chasis. The nipple is at the exact horizontal level of the IMF, but above the lower contour of the gland. Grade 2, moderate. Nipple is definitively below the IMF, but still above the lowest breast contour.
And grade 3.
Severe. The nipple is so far below the IMF that it is the absolute lowest contour of the breast, pointing at the floor.
What about pseudoptosis?
That's an illusion. The gland has bottomed out below the IMF, but the nipple is actually at or above the IMF level. Common postpartum or years after a reduction.
For minor matrosis, we use Benelli's round block. But if you suture a massive outer circle of skin to a tiny inner circle, shouldn't the sheer tension stretch the areola into a massive pancake?
It would, if not for the engineering of the round block. You de-epithelialize a wide ring of skin. Then you use a heavy, permanent, non-absorbable purse string suture woven through the epidermal edge. You pull it tight like a drawstring.
That leaves bunched up, pleated skin.
Right, so you use the skin compensation suture. You take wide horizontal bites of the bunched outer dermis, but very narrow vertical bites of the NAC. It actively minimizes puckering. And that buried permanent purse string forms a rigid wall that stops the areola from stretching out radially.
It prevents the parenchyma from herniating. Okay, let's shift gears completely to breast augmentation and the alloplastic controversies. Break down implant taxonomy first. Shell, content, shape, and pocket site.
Okay, the shell is universally a medical-grade silicone elastomer, but the surface can be smooth, aggressively textured, or micropolyurethane foam. The content is liquid silicone gel, cohesive gummy bear gel, or sterile saline. Shape is round or anatomical teardrop.
And the surgical pockets. Walk me through the 4.
Subgranular is deep to the parenchyma, but superficial to the pec major fascia. Subfacial, described by Graf, elevates the thin pec fascia off the muscle and places the implant under it.
And subpectoral.
Subpectoral, or partial submuscular, places it deep to the pec major, but you release the inferior muscular attachments. The lower pole rests under the gland. And finally, total submuscular, advocated by Spear. It's totally walled off deep to the pec major, serratus anterior, and rectus abdominis fascia.
Let's focus on Tebbett's dual plane technique for the subpectoral pocket. Give me a clear analogy on how it prevents the snoopy-nosed double bubble deformity in a slightly ptotic patient.
Think of it like a sliding mechanical joint.
Mm.
If you just do a standard subpectoral pocket in a ptotic patient, the muscle grips the implant high on the chest, but gravity pulls the loose breast tissue down over it. That's your double bubble.
The implant is high, the gland is low, so Tebbit separates them.
Yes, he performs an additional subglandular dissection, lifting the breast parenchyma off the anterior surface of the lower pec major.
What's the analogy here?
Imagine the pec major muscle is a tight elastic sleeve gripping the top half of the implant. The ptotic breast tissue is a separate looser jacket worn over that tight sleeve. By severing the connections in the lower pole, the loose jacket can freely slide and redrape independently over the lower pole of the implant.
The implant provides static volume, and the gland smoothly slides over it. Perfect. All right, I need a rigorous review of the silicone controversies. Let's start with the FDA ban in 1992.
It was mass hysteria. Media reports linked silicone gel to autoimmune diseases and breast cancer. The FDA instituted a sweeping ban, forcing the industry to use saline, but a decade later the data caught up.
The UK's independent review group in 1998, right?
Exactly. The IRG published a monumental meta-analysis finding absolutely zero statistically significant association between silicone implants and autoimmune or connective tissue diseases.
And the US IMNAS report in 1999.
They concluded the same thing, and they noted that fascinating fact. Ordinary store-bought cow's milk and infant formula contain significantly higher levels of ambient silicone than the breast milk of nursing mothers with ruptured implants. The FDA finally lifted the ban in 2006.
Okay, autoimmune disease was a ghost, but BIA-ALCL is very real. Break down the duck study and explain odds ratio versus absolute risk.
BIA-ALCL is a rare T-cell lymphoma arising in the inflammatory fluid and capsule around a textured implant. In 2008, Dutch researchers found a definitive link. The odds ratio was staggering 18.2 for women with implants versus those without.
18 times higher risk sounds terrifying to a patient.
It does, but you have to explain absolute risk. The odds ratio is mathematically huge only because the baseline incidence in the general population is virtually zero. At the time, there were only 34 confirmed cases worldwide out of 10 million implanted women.
So the absolute risk to one patient is incredibly low.
Roughly 1 in 30,000 to 1 in 300,000, depending on the texturing. It's rare. And if caught early as a late-onset seroma, it's generally completely curable with a surgical en-bloc capsulectomy.
Well, let's talk about corporate fraud. The PIP scandal. What happened there mechanically, and what do the guidelines dictate we do today?
PIP was a French company that fraudulently filled their shells with unapproved industrial-grade mattress silicone to cut costs. The chemical composition aggressively degraded the shell, leading to catastrophic rupture rates of 15 to 30% within 10 years.
Did the mattress gel cause cancer when it ruptured?
No. The UK's MHRA ran exhaustive toxicology tests and found absolutely no evidence of genotoxicity. It caused intense local inflammation and siliconomal lymphadenopathy, but not cancer.
So what's the surgical management?
Proactively offered to remove or exchange them. If the capsule is thin and the implant is intact, just remove the implant. But if you encounter extensive capsular thickening or severe contracture, the guidelines mandate a thorough biopsy and a total capsulectomy.
Speaking of capsules, let's go over the Baker classification of capsular contracture and then the modern biofilm debate.
Baker graded it purely on physical exam. Grade 1 is perfect, feels completely natural. Grade 2, the implant is palpable and slightly firm, but no visible distortion. Grade 3, easily palpable, distinctly firm, and visible distortion. It looks too round or rides high.
And grade 4?
Rock hard, tender, actively painful, cold to the touch, with marked visible distortion.
For decades, we blamed talc from gloves. Why do we now blame biofilms?
Biofilms are 3D aggregations of bacteria that attach to the silicone shell and secrete a protective licocalyc slime layer, making them impervious to antibiotics. Microbiological studies sonicated these capsules and found Staphylococcus epidermidis in up to 90% of severe Baker III and IV capsules.
Compared to what, 12% in normal capsules?
Exactly. This subclinical biofilm infection triggers chronic macrophage activation. They release cytokines, transforming fibroblasts into myofibroblasts, causing massive collagen cross-linking. That's why we meticulously use no-touch techniques, Keller funnels, and triple antibiotic washes today.
If a patient has a grade 4 Fick contracture, why is open capsulectomy preferred over the old closed capsulotomy?
Closed capsulotomy is barbaric. The surgeon would violently squeeze the breast in the clinic until the internal capsule literally popped under hydrostatic pressure. It has a massive recurrence rate because you leave the diseased biofilm behind and you risk rupturing the implant itself.
So open capsulectomy is the standard.
Yes, you dissect the entire fibrous disease capsule out en bloc. It drastically lowers recurrence by removing the microbiological trigger.
Phenomenal breakdown. Let's move to congenital deformities. Outline the tuberous breast deformity and the von Heimberg classification.
Tuberous breast is a deformed envelope, not just a small breast. 4 key features: deficient horizontal and vertical base, a tight elevated IMF, an elongated tubular shape because the fascial ring restricts radial growth, and severe herniation of the parenchyma into the NAC, stretching the areola.
How does von Heimberg map this?
Type I is constriction of the lower medial quadrant only. Type 2 involves lower medial and lower lateral hypoplasia, so the whole lower pole, but sufficient subareolar skin. Type 3 is deficient lower pole with definitively deficient subareolar skin. And type 4 is severe circumferential constriction of all 4 quadrants, leaving a minimal tuberous root.
How does that change your surgical strategy? Type I versus type 4.
Type I might just need a small implant or targeted fat grafting, but type 4 is rigorous. You must aggressively score and release those dense parenchymal constrictions, literally slicing the gland to unfurl it.
Then you lower the IMF.
Right, lower the IMF, insert an expander or implant, and you absolutely must do a circumareolar mastopexy utilizing the Benelli round block to fix the areolar stretching and prevent herniation over the new implant.
Let's switch to male anatomy. Gynecomastia. Give me the Simon classification.
Grade 1 is small enlargement, no skin redundancy. Grade 2A is moderate enlargement, tight skin. Grade 2B is moderate enlargement with visible skin redundancy. Grade 3 is massive enlargement with profound pendulous skin redundancy, essentially looking like a female breast.
And the etiology, the 3 Ps. We have to rule out systemic disease before operating.
First, physiological. Neonatal due to maternal estrogens, puberty hormonal surges, and old age as testosterone declines. Second, pharmacological.
The highly tested drugs.
Yes. Cimetidine, digoxin, spironolactone, cannabis, and anabolic steroids. You must take a rigorous drug history. Third, pathological. Investigate for liver cirrhosis, hypogonadism, estrogen-secreting testicular tumors, and Klinefelter syndrome, 47,000 XY. Check the testicles before you book lipo.
If it's idiopathic, how does parenchymal density dictate our tools? Grade 2A versus grade 3.
For fatty mild to moderate deformities, liposuction is highly effective. Ultrasound-assisted liposuction, or UAL, is revolutionary here. It emits sound waves that actively cavitate and liquefy the dense, fibrous parenchyma that standard cannulas just bounce off of.
But if UAL fails on a massive, dense central disc,
You must pivot to direct excision, like Webster's semicircular periolar excision. You physically dissect the glandular disc under direct vision. For a massive grade 3 with pendulous skin, you abandon hidden scars and use radical skin excision patterns or formal mastectomies.
all right, the heaviest section, breast oncology. Let's rapid-fire genetic risk factors. BRCA1 and 2 and histological markers.
BRCA1 carries a 65% lifetime risk of breast cancer and 46% for ovarian. BRCA2 is a 57% breast cancer risk and 23% variant.
And benign biopsy showing high-risk markers.
Atypical ductal hyperplasia, ADH, or atypical lobular hyperplasia, ALH, confer a 5-fold increased risk. Lobular in situ neoplasia, LISN, carries an 11 times greater risk, and it applies equally to either breast.
Let's jump to TNM staging. I'm going to press you on the T stage, specifically what makes a T4 tumor.
T1 is 20 millimeters or less. T2 is 20 to 50. T3 is greater than 50. T4 is the critical threshold. A tumor of any size, demonstrating direct physical extension to the chest wall or overlying skin.
What exactly counts as chest wall invasion in T4A?
This is the trap. Direct invasion of the pectoralis major muscle does not count. T4A means deep invasion into the ribs, intercostal muscles, or serratus anterior.
T4B is skin involvement.
Yes, visible ulceration, satellite nodules, or clinical skin edema like peau d'orange. T4C is both chest wall and skin. And T4D is inflammatory breast carcinoma, driven by diffuse dermal lymphatic invasion.
What about end staging for lymph nodes relative to physical exam?
N1 is metastasis in mobile ipsilateral level I or I nodes. N2A means those level I or I nodes are clinically fixed or matted. N3 involves aggressive spread to infraclavicular or supraclavicular nodes.
How does receptor status and molecular subtyping change the adjuvant management?
Receptor status dictates targeted therapy. 70% are ER positive. Premenopausal women get tamoxifen to block the receptor. Postmenopausal women get aromatase inhibitors like letrozole to stop peripheral estrogen production.
And HER2 positive.
About 15% overexpress HER2. We use trastuzumab or Herceptin, a monoclonal antibody that binds the receptor and flags it for immune destruction. Triple negative lacks ER, PR, and HER2, so we rely on highly toxic traditional chemo.
Microarray gene profiling gives us the molecular subtypes, right? Luminal A, luminal B, triple negative, and HER2 enriched.
Exactly. Biology dictates therapy now, not just anatomical size.
Okay, surgical indications. Wide local excision versus mastectomies, and I want to challenge the oncological safety of skin-sparing versus nipple-sparing mastectomy.
WLE aims for conservation in stage 1 or 2. It's contraindicated for multicentric disease or large tumors in very small breasts. If you have to do a mastectomy, a skin-sparing mastectomy preserves 90 to 95% of the native skin envelope for immediate reconstruction.
But a nipple-sparing mastectomy, NSM, preserves the actual nipple areola complex. Aren't you knowingly leaving a concentrated core of ductal tissue directly retroareolar?
You are. You leave a millimeter or two to preserve vascularity. So you take a separate frozen section biopsy from directly under the NAC during the operation. If it shows cancer, you amputate the nipple. But with perfect patient selection, the retroareolar recurrence rate at 5 years is roughly 3 to 6%, consistent with traditional mastectomies.
Perfect patient selection meaning what?
Tumors less than 3 centimeters, located peripherally far from the central nipple, with no skin involvement and no clinical axillary disease.
How do we stage the axilla surgically if pre-op scans are clear?
Sentinel lymph node biopsy, or SLNB. You inject a radioactive isotope and blue dye. The lymphatics carry it to the very first draining node, the sentinel node. You excise it. If it's negative, the rest of the axilla is spared.
But if it's positive?
You proceed to a formal axillary lymph node clearance.
And the anatomical boundaries of those axillary levels?
Defined entirely by the pectoralis minor muscle. Level 1 is inferolateral to the lateral border of pec minor. Level 2 is directly posterior to the belly of pec minor. Level 3 is superomedial to the medial border at the apex.
All right, breast reconstruction techniques. Talk to me about Clough's oncoplastic levels for partial defects after a WLE.
Cleft level 1 is for a minor volume loss of 20% or less. You perform a wide dual plane undermining and slide the native tissue to close the dead space. Cleft level 2 is for a massive loss of 20 to 50%. You use complex therapeutic mammoplasty like a WISE pattern reduction to radically reshape the remaining parenchyma and almost always do a symmetrizing reduction on the opposite breast.
For total reconstruction with implants, how does the Mentor Siltex Becker expander work?
It's a dual lumen device. The outer lumen is pre-filled with cohesive silicone gel. The inner lumen is an empty balloon connected to a remote percutaneous port. You inject saline over weeks to expand the skin. Once expanded, you pull the port out of the chest under local anesthetic. A self-sealing valve snaps shut, and the expander instantly becomes the permanent implant. No second major surgery.
And how has a cellular dermal matrix, ADM, revolutionized subpectoral implant reconstruction?
Before ADM, you had terrible lower pole coverage because the pec muscle only covers the top half. ADM is a sterilized cadaveric or porcine dermis scaffold. You suture it to the inferior border of the released pec major and down to the new IMF on the chest wall.
It acts like an internal hammock.
Exactly. It completely covers the vulnerable lower pole of the implant, allows for single-stage reconstruction without harvesting the patient's back muscle, and significantly reduces long-term capsular contracture rates.
Transitioning to autologous tissue flaps, detail the vascular anatomy of the tram flap versus the DIEP flap.
Both harvest the exact same elliptical paddle of skin and fat from the lower abdomen. The tram is a pedicled flap. You leave the tissue attached to the rectus abdominis muscle, relying on the superior epigastric vessels flowing down from above.
And the DIEP?
The DIEP is a free flap. You dissect out the tiny perforating vessels coming off the deep inferior epigastric artery, sparing the entire rectus muscle in the abdomen, and reanastomose those tiny vessels to the internal mammary vessels in the chest.
I want to use the sprinkler analogy to explain the perfusion zones of that abdominal skin paddle. Zones 1 through 4.
Think of the main perforator entering the flap as the main water pipe of a sprinkler system. Zone 1 is directly over that perforator on the ipsilateral side. The pressure is highest here. The grass is green and robustly irrigated.
As the water sprays outward, it crosses choke vessels and loses pressure.
Right. Zone 2 is across the midline. Decent pressure. Zone 3 is ipsilateral, but far lateral. Pressure drops. Zone 4 is the furthest point away on the extreme opposite lateral side. Anatomically, it's normally supplied by the contralateral superficial circumflex iliac artery, or SCIA.
So in the analogy, Zone 4 is the driest, brownest grass at the edge of the yard.
Exactly. The pressure from our single pedicle is too weak to reliably perfuse zone 4. It's highly ischemic and will suffer from fat necrosis. You almost always proactively excise and discard zone 4.
If we're doing a tram and want to spare muscle, break down the Nahabedian MS tram classification.
MS0 means the entire full width of the rectus muscle is harvested. MS1 preserves just the lateral segment. MS2 preserves both lateral and medial segments, taking only a narrow central strip. MS3 is essentially the DAP flap. The entire width of the rectus is completely preserved.
Briefly review the alternative autologous flaps, LD, SGAP, IGAP, TUG.
LD flap is a pedicled myocutaneous flap based on the thoracodorsal artery. SGAP and IgA are gluteal-free flaps based on the superior and inferior gluteal artery perforators, respectively. TUG uses the upper medial thigh, based on the ascending branch of the medial circumflex femoral artery supplying the gristless.
What about NSE reconstruction techniques?
The classic is the skate flap by Little. You lift local skin flaps from the reconstructed mound-like wings to create 3D nipple projection. Then you apply a full-thickness skin graft to the peripheral raw area to recreate the areola.
Other options.
Star flap or CV flap. You can insert a tiny central strut of bank autologous costal cartilage into the core to maintain projection long-term.
Outstanding. Section 7. Chest wall deformities and reconstruction. Pectus excavatum. What is the Haller index, and how do we surgically correct it using ravage versus Nuss?
Pectus excavatum is a funnel chest, caused by abnormal overgrowth of costal cartilages pushing the sternum backward. The Haller index is a CT ratio of the transverse internal width divided by the antero-posterior diameter. Normal is 2.5. A severe deformity requiring surgery is greater than 3.25.
Compare the biomechanics of ravage and Nuss.
Ravage is aggressive and open. You resect the overgrown cartilages, perform transverse osteotomies across the sternum, pull it forward, and stabilize it with steel wires or bars. The Nuss procedure is minimally invasive. You pass a massive convex steel bar retrosternally under thoracoscopic visualization.
Then you flip it.
You forcefully rotate the bar 180 degrees. The convexity violently pops the sternum forward into normal position. It stays for 2 to 3 years to remodel the chest.
But why is Nessus strictly for kids and adolescents?
Because adolescent costal cartilages are pliable and flexible. They can withstand the rapid remodeling force. The adult chest wall is heavily ossified, calcified, and inflexible. If you try to flip a Nuss bar in a 45-year-old, you'll cause catastrophic rib fractures or a massive flail chest. Adults require the open ravage.
Describe Poland's syndrome.
It's the complete congenital absence of the sternocostal head of the pectoralis major muscle, usually accompanied by ipsilateral breast hypoplasia and brachysyndactyly, which are short, webbed fingers.
And the embryology.
It's believed to be a transient vascular anomaly, specifically an interruption of the embryonic subclavian artery around the critical 6th week of gestation.
Transitioning to sternal wounds post-cardiac surgery, give me the Paralero classification.
Type A is acute within the first week, presenting as serosanguinous discharge without osteomyelitis. Type 2 is between 2 and 4 weeks. Fulminant, acute, purulent deep mediastinitis with osteomyelitis and sepsis. Type 3 is chronic, months to years later, with a chronic draining sinus tract and retained infected wires, but not acutely septic.
What are the flap options to obliterate that massive, deep mediastinal dead space?
First, radical debridement and NPWT, or VAC dressing, as a bridge. Then you need highly vascularized tissue. The workhorse is the pectoralis major muscle, used as a turnover or advancement flap, but it only reaches the upper 2/3 of the sternum.
If the defect extends to the xiphoid,
You must use a rectus abdominis flap, specifically the VRAM vertical rectus abdominis myocutaneous flap.
and what is the major vascular trap with planning a VRAM in a cardiac bypass patient?
The VRAM is supplied from above by the superior epigastric artery, which is the direct continuation of the internal mammary artery, or IMO. If the cardiothoracic surgeon harvested the IMAs for the coronary bypass grafts, they've severed the blood supply to your VRAM.
If you harvest it, it instantly necroses.
Exactly. You must read the op note. If both IMAs are gone, you might resort to a pedicled omental flap harvested laparoscopically.
Briefly touch on alloplastic materials for skeletal chest wall reconstruction after massive oncologic resections.
You need rigid support to prevent paradoxical flail chest. We use PMA sandwiches. You place polymethylmethacrylate bone cement between 2 layers of synthetic polypropylene mesh.
But the curing process is dangerous.
Highly exothermic. It generates massive heat that will cook underlying vital structures. You must protect the heart and lungs with thick laparotomy pads and ice-cold saline while it cures. In infected or irradiated fields, we abandon synthetics and use thick biological meshes like ADMs, which resist infection and provide enough tension to stabilize the chest.
Rounding the final corner, Section 8, posterior trunk reconstruction. How do we approach these defects regionally? Start with cervical.
For cervical or upper neck, the trapezius muscle flap is your best option. But you must preserve the superior fibers of the trapezius during harvest. If you take them, the patient gets a permanent debilitating drop shoulder deformity.
Upper thoracic.
Latissimus dorsi, lower trapezius, or scapular fasciocutaneous flaps based on the circumflex scapular artery.
Lower thoracic.
Latissimus dorsi based on secondary posterior intercostal perforators, or intercostal artery perforator, ICAP, flaps.
And lumbar and sacral.
Historically, random pattern transverse lumbosacral flaps were used, but they suffered devastating ischemic necrosis at the tips. Today, the gold standard is the lumbar artery perforator flap. By isolating a specific dominant lumbar perforator, the flap is vastly more robust and reliable. You can also use an SGAP flap rotated upwards.
Well, that covers the entire reconstructive algorithm, from the breast footprint through reductions, implant controversies, oncology staging, DIEP flaps, to physically rebuilding the bony thorax.
It is a massive amount of material. We've discussed replacing lost tissue with highly advanced biological meshes, intricately matched perforator flaps, and complex mechanical sutures. But as you study for your exams, I want you to think about the absolute horizon of tissue engineering.
Where are we headed?
We are currently moving from merely rearranging autologous tissue robbing Peter to pay Paul to the incredibly real potential of bioprinting patient-specific, fully vascularized breast and chest wall constructs directly from their own harvested stem cells.
Wow.
When we can print a breast mound that naturally integrates without a silicone shell, or print a living costal cartilage matrix for a NUS procedure, how would that fundamental shift in biology change the very surgical algorithms you just memorized? That is the future.
That is the exact kind of high-level, forward-thinking synthesis the board examiners absolutely love to hear in Aviva. They don't just want to know that you memorized the past, they want to know that you are actively thinking about how the field evolves. We want to hear from you as well. Please leave a comment or a specific question about this breast and chest wall chapter. Let us know exactly which complex mechanism, which staging criteria, or which specific flap vascular anatomy you want us to break down next. Get to the MedSync ANKI deck, keep drilling those facts, understand the why behind the what, and we will see you on the next deep dive. Keep grinding.